Hello. I'm Karen Stevens, and as most of you know, I do some of the vestibular rehab at the clinic here, and I just wanted to talk to you this evening a little bit about vestibular rehab beyond BPPV, or benign positional paroxysmal vertigo, which most people associate with vestibular rehab. But before I tell you what we're going to talk about this evening, I just want you to have a little think about your own experience of vestibular rehab or vestibular pathologies, what you think you might know, what you know you don't know. So just for 2 seconds, in your own minds, have a think, and then you're going to score yourself out of 10. So 10 being an absolute expert, and 0 being I know nothing. So take a post-it note, grab a pen and write down your own score. Do it in big letters because you're going to need it later. So don't think too hard, nice and quickly. And then when you've written a number down, just turn to the person next to you, and again, in 30 seconds, just have a quick conversation about your own experience of it and a couple of ideas of where vestibular rehab might be helpful. So sort of pathologies or situations where you think it might be a helpful thing to do.
Okay. I'm completely obvious.
I've seen it.
And so it's more of a central problem rather than so that's what I'm seeing. And what I have to be
She's actually got it.
That's what I do.
So, council, we have multiple connections. So leave most of them have been sort of shifted easy
Okay, lovely.
So we get dizziness and I suppose we restrict confidence and various.
Going to stop you there. Just any out of those conversations, or any sort of pathologies that came out that you think might be helpful, that vestibular rehab might be helpful for, just so I get an idea of what people are thinking? No.
I said I saw it with MS patients.
Yep, super. So central signs with MS. Lovely. Anyone else?
I've seen with quite sort of low tone patients where they've come into other things, and actually then I've queried whether there is a higher thing going on, not just
Yeah. So
proprioceptive,
whether there's a
but
sort of central,
yeah, there's a bit more than that. Yeah.
like a central processing.
Yeah.
Sort of thing. Yeah.
It's a bit too much coming through. Not
Could you
processing?
Could you say people who like with anxiety issues as well, people who have
Certainly they might well have some dizziness issues.
subjective sort of dizziness.
Yeah, absolutely. So subjective vertigo is one thing.
Seasickness, is that coming to?
Seasickness, motion sickness.
Motion sickness.
Yeah, lovely. So some good ideas there. So what I was going to actually cover today was just give you a really quick feel for 3 different areas of vestibular rehab. I'm not going to talk about the ins and outs of the anatomy and the physiology. That's not really what I wanted to kind of talk to you about today. Really just to give you a bit of a feel for these 3 different areas. So vestibular neuritis, visual vertigo and vestibular migraine. Give you just a really quick feel of what they might look like, what their presentations would be, some of the key features of them really, some of the key assessment tools that you can use, and just a really quick feel for what sort of treatment options there are available. And then just give you some sort of signposting of resources that you can go to have a little look. And I've tried to keep those as accessible as possible, so things like podcasts and YouTube resources. So I'm not talking about academic journals, just as tasters really to get people interested. So we're going to start with vestibular neuritis, which is people are often diagnosed with labyrinthitis. Most people have heard of labyrinthitis. Vestibular neuritis is your inflammation of your cranial nerve, and it doesn't involve your hearing, whereas labyrinthitis involves hearing and balance problems. So that's just the difference between the 2. Vestibular neuritis is one of the commonest causes of a vestibular hyperfunction. So by that we mean one side of your vestibular system is giving less information than the other side of your vestibular system. And the vestibular system works together. So it's a bit like a prop aeroplane, if you like, so the engines are working as a team. So if one side's not giving as much information as the other, we've got a bit of a problem with what information's being fed back to the central nervous system. So it's a problem with your peripheral vestibular system, so we're talking about the inner ear and the cranial nerve component, not the central processing component of it. So it's worth thinking of the vestibular system in sort of three areas. You've got your peripheral apparatus within the inner ear, the communication with the brain via your cranial nerve, and then the processing that happens within the brain. So vestibular neuritis is a problem with the peripheral apparatus and the cranial nerve communicating back. Tends to be a very sudden onset vertigo, so real spinning sensation, it's very dramatic, often accompanied with vomiting and lots of disorientation. People really can't get out of bed and often end up calling an ambulance because they think something very, very serious is going on. So it's quite a dramatic, out of the blue sort of presentation. 24, 48 hours it starts to subside, so those very dramatic symptoms tend to drop down fairly quickly, and most people make a full recovery within 6 to 8 weeks roughly. And so that's the sort of normal journey, and most people get better without the need for VR or medications, particularly once the sort of very acute symptoms have gone. Movement's the best thing that they can do. Get up, get moving, get your vestibular system working again. But there's a group of people whose vestibular systems don't compensate very well for any of the damage that's occurred during that infection, or that inflammatory process that's caused the problem in the first place. And for those people, they're the sorts of clients that I see. So they tend to be much more chronic, they tend to have a lot more anxiety sort of around the symptoms that they're experiencing, because they're pretty unpleasant feelings of disorientation. And they just haven't been able to compensate within the nervous system. The key thing, one of your key outputs of your vestibular system is your vestibular ocular reflex, or VOR, which essentially keeps our eyes stable, our vision stable whilst we're moving. So when we're moving, our eyes don't bounce up and down. As we're walking, vision stays clear. That's your VOR doing that for you, and that's where these clients have problems. So the world starts looking like it's moving, they become quite disorientated because of that. Okay? So thinking, so someone might come in, they'd just say, oh, I had this very intense sudden start of vomiting and spinning, and and I knew I'd had a chest infection before. Already my brain's saying, I think that's probably a vestibular neuritis. We've probably got some reduction in the inflammation coming in. So some of the tests I might look at, some of these ones, and the head thrust test we're going to go through in a minute, because it's a nice key one that really does help us diagnose a hyperfunction. The dynamic visual acuity test is where you take a standard vision test chart, you get someone to read the lowest line that they can read, and then you stand behind them and oscillate the head side to side and ask them what lines they can still read. And it's normal to have about a 2-line difference. Any more of a difference would suggest that they can't stabilise their vision whilst movement's occurring. So that would be one test that would start to suggest there's some problem with stabilising their vision. For Duca's stepping test, Ian, come forwards. So, I usually use this grotty piece of tape on the floor, but you want someone standing so you know where they're starting. So if you could just stand for me, not against the wall. Put your arms out in front of you, start marching on the spot, and then close your eyes.
Diagnosed with something catastrophic.
And you get someone to do that for around 30 seconds.
Oh dear.
Oh.
Oh dear.
I've just had 8 pints in there and that
Almost asymmetric.
Okay, so Ian knows what happens. Thank you. Sit down. So a normal test would be, you can up to about 50 centimetres forwards and 10-15 degrees off to either side is considered kind of normal. Outside of that, you would consider it a test that's indicating one side of your vestibular system is giving less information than the other. So I have had clients who've done this. Across the room. So that's a nice, neat, and it's a nice one that you can reassess as well. And then you'd run through some of your standard balance tests, so changing your conditions, so eyes closed, foam underneath, just to start taking out your other balance system, so you're sensitising it to your vestibular system. So the next, going back to the head thrust test, we're going to go through it in a minute. So you're going to work in pairs. The client is going to be sat down. You're going to sit in front of the client. I'm going to demonstrate as well in a second. Pop your hands either side of the head, and you'll be just moving the head that sort of speed from side to side, and the client's looking at the bridge of your nose the whole time. And then periodically, you change direction that you're moving the head. And what you're looking at is, does the vision stay looking at the bridge of your nose, or do you see a little jump across with the eyes? A normal test is if you don't see any of that jumping of the eyes. Okay. Shall I use Ian again? Do you want to come and sit on? So I would normally sit on a gym ball or something in front just because that's easier, so I've popped my hands either side of Ian's head. He's looking at the bridge of my glasses, which is nice and relaxed, which is lovely, and then I change direction.
Am I doing it right?
No.
Am I doing it wrong?
Fine, you're fine. Okay, so grab a seat. If you just work with the person next to you and just have a feel. Firstly, just have a feel of, it's quite difficult to do unless someone's completely relaxed. So lots of clients it's quite difficult to do because they slightly resist you.
Do you find that some people because of course they have this and they compensate by having a stiff neck as well, don't they?
Absolutely, So it is quite. So I think that's why it's useful to have a sort of battery of things to try. But if you just head back and just have just a very gentle go with each other. So let's have a little. Do you want to go over that?
Yeah, might be a good idea.
So you'll need to bend down a little bit. As I say, normally I'd sit in the gym walls. Lovely.
Look at the bridge of my nose, also turn the head side to side. And then slowly.
Good. Hair out the way. So possibly, Matt, slightly less range, but slightly more speed.
Oh, right, more speed.
So you're looking for not a jerking movement. I remember doing it. It is. You're looking for.
So positive. I'll show you. I've got a video in a minute. But positive test that kind of does that. Whereas you would get just a smooth staying on that point.
Right, bridge of your nose.
So switch over. Have a go.
Oh, sorry, me off. That's me.
Do you try and keep the head at the end of the movement?
Yeah. I'd go tiny bit faster in for you. Just that's it.
I think when you do it, you just go one direction.
Yeah.
Just
So
just
just have a quick switch
one
over.
way. That's right, Karen, isn't it? It's left, right, one direction, the other direction, isn't it? You don't go boom, boom.
Do you change?
Yeah.
But then change after.
So,
Have a go. So I would stop.
So bamboo,
So
at the
here's
end.
my-
Just
so I
one,
can-
just one.
You can almost sense it.
You're moving your head for me, that's great.
Oh no, it's weird. I don't like that.
so you just do it one way.
Okay, guys, if you... I'll just let them do it one more time. If you two want to have a little look.
That's it. It's boom, 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 boom.
So just on the here, so grab a seat again. I've just got a little video here. Hopefully you can see. If you just pass it along. This guy's got a positive test. So if you watch his eyes, what you'll see is a big jumping. Oh, yes. Can you see, particularly if you watch the white of his eyes?
Oh yeah.
Yeah. So do you want to?
And he had neuritis.
I don't know.
Oh,
It just
right,
says it's a
right.
positive test. So guys, do you want to just press play in the middle there?
Oh, right, yeah. She just keeps going, doesn't it? Do they blink a lot as well, you say? Or
What?
it's,
I think different people respond in different ways. It's a funny test. What you're not looking at is symptoms, really. Put the thingy down. White film.
There it is behind the pillar.
Thank you. Sorry. What you're not, some people find it makes them feel unpleasant, but that's not really what you're looking for as a clinician. It's about what the visual response is. So that's a really useful test, but I think it's the battery of tests that gives you the most information, really. So that's our man. So one of the key so once you've been through some of those tests, the most effective, and there's quite a lot of literature to support it, treatment options are using gaze stabilisation exercises, which makes sense. We're looking at a condition that causes problems with gaze stabilisation, so we get people to try and relearn their ability to stabilise their gaze, really. So this is where your post-it note comes in. So what you're going to do is take your post-it note with your number written on it, hold it out, and Matt's off, hold it out in front of you. So I'm using my thumb, but you're using your post-it note. That number that you wrote on there, keep your vision focused on it, but moving your head from side to side. Okay? And you want to move your head quite quickly. And actually you're going to ask your clients to do that for a minute and as fast as they possibly can. Now imagine you're feeling a bit dizzy, a bit disorientated. It's quite an unpleasant exercise, so you can stop. And then you can do the same thing up and down. So, yeah, lovely, beautiful technique here. Lovely, super.
I was used to saying yes all the time.
Matt's doing something slightly weird with his eyes. So they're your kind of basic exercises, and what I tend to do is I would just give them one to start with. Send them away and see how sensitive they are, because it might be they come back and go, I do that for 10 seconds and then I'm sick all day. You go, ooh, okay, then we need to modify. Or they might come back and go, I didn't really feel anything at all whilst I was doing that exercise, so you know that they're ready to progress onto something a little bit harder.
So if you said that they would get worse after a few seconds,
Yeah.
would you say keep practicing it and let's see how it brings it down to the 30 seconds?
Yeah. So yeah, usually I would bring it right down. So you do want them to feel a little bit of their symptoms. So a little bit of symptom increase is actually what you're looking for. And it's a really nice way to work with someone around learning if you increase your symptoms, how they can dampen them back down again. So I often use it as that kind of tool as well. Like, it's okay to increase your symptoms. It's not pleasant, but it's okay. But actually you have the capacity to dampen them back down again as well, and it's a nice tool for that. So in terms of how you progress them, you could use them I always start in sitting, however good I think they are, I always start in sitting. Go up into standing, go to walking, work through your various more challenging balance positions, so feet together, tandem stand, one leg, on phone, you can make it as difficult as you think they can cope with. Change the background, so always start with a white background, or as visually uncomplicated as possible, and then you can stick your post-it note on a more complicated visual background, and you have to pick the target out from that. Change the planes, we talked about side to side, up and down. You can do diagonals as well, it depends what the problems were. I saw a lady who was having problems driving, flicking her eyes up and down to the mirror, so we did diagonals and that really helped her. And then you can also use imaginary targets, so they close their eyes, imagine that they're looking at a target and do the same exercise. So there's lots of ways to play with it, and that depends on what the patient's goals are and such like. So that was a whistle-stop tour of vestibular neuritis. These are some of the resources. The Susan Herman book is brilliant. It's got loads of information about all the different vestibular rehab conditions and exercises and things, so it's worth looking at if you're interested. And there is a brand new edition out now as well.
And then I'll give you handouts at the end. So there's a couple of YouTube channels which are really good. This one here has got all the tests on, so you can have a little look at some of the tests and some of the